Hello everyone. Today I am going to talk on one of the very common problem, that is allergic rhinitis. Allergic rhinitis is the most common type of chronic rhinitis, which is affecting about 10 to 20% of the population. And interestingly, it affects about 400 million people worldwide. Allergic rhinitis is associated with a significant problem. It may impair the quality of life, it may impair the sleep, and it can work performance. It can affect the work performance. So allergic rhinitis, though it is considered is a very relatively a mild disease, but it can affect significantly the patient problem. Allergic rhinitis represents a component of a systemic airway disease involving the entire respiratory tract. So though the allergic rhinitis is considered as a local disease which involves the nasal cavity, but it may be a part of a systemic airway illness, because we know that upper and lower respiratory tract are having a very strong relationship physiologically, functionally, and immunologically. So any disease affecting the upper respiratory tract may affect the lower respiratory as well. The allergen exposure of upper airway, it not only leads to local inflammatory response into the nasal cavity, but it can also affect the lower respiratory tract. And so it is not surprising that rhinitis and asthma, they coexist very commonly. And as per the data, it says that about 30% patient of rhinitis or allergic rhinitis, they have asthma, and about 70% patient of asthma, they may have allergic rhinitis. Now, a brief about pathophysiology of the disease. The allergen exposure, it causes the infiltration of the nasal mucosa with a lot of inflammatory cells like mast cells, T cells, macrophages, etc. And these cells, especially the T cell, what we call as T helper cells, they release various cytokines, primarily the interleukins, that promote the production of immunoglobulin E. And immunoglobulin, which is produced by the plasma cells, it is acting on the mast cells to release the various chemical mediators like histamine, leukotrienes, and so many others. And these chemical mediators, they are responsible for vasodilatation, increased vascular permeability leading to edema, itching, running nose, mucus secretion, and smooth muscle contraction in the lungs. The early phase response is mediated by cytokines, whereas late phase response in allergic rhinitis is mediated by cellular process. The clinical features of allergic rhinitis can be classified broadly into nasal and non-nasal symptoms. The nasal symptoms are essentially anterior and posterior rhinorrhea, that is running of nose, the sneezing, the nasal blockade, and our itching of the nose. Among the non-nasal symptoms, the ocular symptoms, which is we call as rhinoconjunctivitis, it can predominate, and primarily it is characterized by itching, redness, and tearing from the eyes. There could also be itching of the palate, postnasal drip, and cough as the symptom in allergic rhinitis. Now, 30% patients of allergic rhinitis, they suffer severe symptoms like anaphylaxis, and in few cases there could be fatal symptoms like bronchospasm, laryngeal edema, cyanosis, hypotension, and shock. So allergic rhinitis in few cases, not though very common, but in very extreme cases, it can be a life-threatening problem. Now, allergic rhinitis is classified broadly into two types. The earlier classification, which was known as seasonal allergic rhinitis and perennial allergic rhinitis, it has been changed to a new nomenclature. The seasonal allergic rhinitis is known as intermittent allergic rhinitis, and perennial allergic rhinitis is known as persistent allergic rhinitis. Now, intermittent allergic rhinitis, the symptom in this case persist or they are present less than 4 days in a week and less than 4 consecutive weeks. So the timing are important. So it is less than 4 days in a week and less than 4 consecutive weeks. Whereas in persistent allergic rhinitis, the symptom persists for more than 4 days in a week and for more than 4 consecutive weeks. So essentially these two classifications, which are based on the duration of symptoms or the onset of symptoms, are used all across. Now coming to the intensity of symptom, it can be categorized as mild allergic rhinitis or moderate to severe. In mild cases, their symptoms do not cause any impairment in the sleep and the person is able to perform his normal daily activity. Whereas in moderate to severe cases, the person can have a significant impact on his sleep and it can affect the activities of daily living. He may miss the school, he may miss his work, etc., etc. Now, as a subclass of allergic rhinitis, there is a condition known as occupational rhinitis. As the word indicates, occupational rhinitis is the rhinitis which is primarily due to certain occupations, exposure to certain occupational irritants or allergens. Now, basically it is an inflammatory problem. The symptoms may be intermittent or persistent as airflow obstruction, hypersecretion, sneezing, etc. And the high-risk professionals, they are primarily the people working in the laboratories, are food processing workers, veterinarians, farmers, and workers in various manufacturing industries. Now, this occupational rhinitis can be because of allergen, where there is IgE mediation, or it can be because of the exposure of respiratory irritants or a chemical irritant, etc. And in this case, the nasal symptoms are often associated with ocular symptoms and even pulmonary symptoms. Then another subtype of allergic rhinitis, which is known as local allergic rhinitis. Local allergic rhinitis is characterized by localized response or localized symptom into the nose, and it is an allergic response which is only limited to the nasal mucosa. The patient has no history of any atopy, and the skin test or the specific test which is done for allergies are negative. But in the nasal mucosa, there is a high production of immunoglobulin E. So there is a very localized problem which is limited to the allergic rhinitis, to the nasal mucosa, whereas the symptom of allergic rhinitis or the local allergic rhinitis are almost the same. The diagnosis of allergic rhinitis is primarily based on the history, a detailed history taking and physical examination. They are the cornerstones of the diagnosis. The symptoms of the allergic rhinitis, which we have seen. Besides that, the history of triggers and relieving remedies are very, very important. What triggers the symptoms and what causes relief of symptoms. So these are the important history points which can give clue for the diagnosis of allergic rhinitis. Also, the patient, most of these patients, they take the medications primarily through OTC route. They go to a pharmacist shop, they buy the medicines. So all such kind of things may help in the diagnosis of allergic rhinitis. There could be certain coexisting condition like asthma, snoring, mouth breathing, sleep apnea, sinusitis, nasal polyp, otitis media. All these chronic illnesses are the coexisting problems. They can also help in the diagnosis of allergic rhinitis. Person may give the history of constant cold throughout the year. This could be another diagnostic feature of allergic rhinitis. There could be a family history of allergic disorder like asthma and eczema, because people of allergic rhinitis mostly are atopic, so they can have such histories in the families. And last but not the least is the physical examination of ENT, ear, nose and throat, along with sinuses, are important for making the diagnosis of allergic rhinitis. Now, the specific diagnostic test, though very commonly they are discussed but not performed in most of the centers, is skin prick test. If this is a very specialized test where the specific allergen is placed on the skin of the forearm, and then the result is seen after 15 to 20 minutes. So there are certain changes on the skin after putting the allergen, and on the basis of that it can be confirmed that the person has the problem of allergic rhinitis. Now, for doing this skin prick test, if the patient has got, or patient is taking any anti-allergic drug or any antihistaminic preparation, he has to stop. Now, in patients who are having very extensive problem or very serious disease or very severe symptom of allergic rhinitis, the stopping of anti-allergic may not be advisable. In such cases, the in vitro test, other than skin prick test, there are a few in vitro tests which are there to identify the level of immunoglobulin E. But these tests are not as specific and sensitive as skin prick test. So for the routine purpose, skin prick test is used, which is more sensitive and also the cost effective than in vitro testing. Treatment of allergic rhinitis is the foremost thing. The first line therapy is avoidance of allergen. If it is known that person is allergic to a particular allergen, then that should be avoided. For symptomatic relief, the irrigation of nasal cavity with saline is a very effective remedy to relieve the symptoms and primarily relieve the nasal blockade. The oral antihistamines, what we commonly call as anti-allergics, they are very effective therapies. They are primarily used as a first line therapy for the treatment of allergic rhinitis. The intranasal corticosteroids, they are available in form of nasal spray, and they are used sometime if the oral treatment with antihistamines are not effective. There are also combinations of intranasal corticosteroid with antihistaminic sprays. So there are combination sprays which are containing antihistamine plus intranasal corticosteroids. So they are again used if the patient has got moderate to severe disease. Another class of drug which is used in the treatment of allergic rhinitis is leukotriene receptor antagonist, which is used either a single drug or in combination with antihistamines. And finally, the allergen immunotherapy, where a specific allergen is given to the patient for a prolonged period to develop the tolerance against a particular allergen. The decongestants and oral corticosteroid may also be required in few cases, but they are usually discouraged for the long-term use. One very important point in the treatment of allergic rhinitis is, while treating allergic rhinitis, there should be constant evaluation for coexisting asthma. If the patient has asthma, then he should be taken prime priority in terms of the management and also to look for the symptoms and improvement for the asthma care. Regarding the allergen avoidance, the various allergens which are common allergens like house dust, mites, molds, pets, pollen, etc., and certain irritants like smokes and tobacco, they are the very common allergens, and avoiding of these allergens are the first line therapy. For avoiding these allergens, there could be an impermeable cover which can be used by the patient, Also, the relative humidity at home can be kept below 50%. Use of window filters, removal of pets or restrict their movement, and in very few cases, there may be a need for using HEPA filters, which are essentially taking the particulate matter, high efficiency particulate filters, which are used for preventing the exaggeration. Now, oral antihistamines, which are used for the treatment of allergic rhinitis, essentially nowadays the non-sedating second generation antihistamines are the first line therapy. Earlier, people were using a lot of medicines like chlorpheniramine and so many other H1 blockers, which were causing sedation. And nowadays, and besides sedation, there was a lot of other side effects like anticholinergic side effects, not very suited for elderly patients, etc. But after the advent of non-sedating, what you call as second generation antihistamines, they became the first line therapy for allergic rhinitis. They reduce the symptoms provided if they are taken regularly during the symptoms or even before exposure of an allergen. Now, these are some of the second generation H1 antagonists which are commonly used: belastin, cetirizine, disloratadine, fexofenadine, loratadine, rupatadine, etc. in different doses. Most of them are used as once daily. They can be used in adults and children. Belastin is not recommended below 12 years of age. Fexofenadine is also not recommended below 12 years of age, and rest of these drugs can be given to the children as well. Now, interestingly, the Indian Academy of Pediatrics guideline of allergic rhinitis gives the doses in children of various anti-allergics, which also includes fexofenadine above 6 months and belastin above 6 years. So this is slightly different than what is recommended as per the international prescribing information, that these drugs can be given in children as well at different doses for the treatment of allergic rhinitis. Now, if we just look the clinical profile in one shot of these second generation antihistamines, we find that the foremost thing, which is known as selectivity for H1 receptor, we find that among all, the belastin, which is relatively a new drug, it was we can say probably it's available for the last 4 to 5 years, has got the highest selectivity for H1 receptors. Fexofenadine, cetirizine, loratadine has also modest activity. Levocetirizine and disloratadine definitely they have higher selectivity than fexofenadine and cetirizine. Now, these selectivities are important because they may impact the therapeutic effect of the drug, as well as the selectivity may also affect the safety of the molecule. The more selective the drug, the better the safety. If you see the half-life, usually they are 14 hours, like in case of belastin, fexofenadine 11 to 15 hours, etc. Now, the important thing about these antihistamines are that allergic rhinoconjunctivitis, as we have seen that some of the patient may have ocular symptoms, for them all the antihistamines are not equally effective. Like loratadine, levocetirizine, loratadine and fexofenadine, some of these drugs, they are not effective against allergic rhinoconjunctivitis. So if there is an ocular symptom, we have the best option for belastin, and probably there can be cetirizine, which may help for relieving the ocular symptoms. Another important aspect in safety is that renal dysfunction, liver dysfunction, etc. So there are certain advantages and disadvantages of each. Fexofenadine, belastin are safe in renal and liver dysfunction. The drug interaction is not seen with cetirizine as well as with belastin. and also with desloratadine, where certain fexofenadine may have certain drug interaction, etc. So, and there are so many other points which are like uses in pregnancies and others. So based on various parameters and these various characteristics, the asthma impact, the allergic rhinitis impact on asthma, which is called ARIA. ARIA is the body which is stands for allergic rhinitis impact on asthma. It has given the scoring for different antihistamines, and here we can see that bilastine scores 10 out of 10, fexofenadine is 9.5 out of 10, the minimal score is given to cetirizine, which is 6, and then rest are 6.5. So probably as per the recommendation of the allergic rhinitis impact on asthma, for the treatment of allergic rhinitis, bilastine stands out to be better option as compared to other second generation drugs. Now, once the oral antihistamines are tried or they are given, there could be a need for intranasal corticosteroids. They are the first line therapy for patients who are having persistent, moderate to severe symptoms. So they are not given for mild symptoms. For mild symptoms, usually the second generation antihistamines are enough. But if the patient has moderate to severe symptom which does not respond to antihistamines, then you may require the spray of corticosteroids. These intranasal corticosteroid can be used as a single drug, or it can be used in combination with intranasal antihistamine. There are so many preparations available in the market. These intranasal corticosteroid, they improve the ocular symptoms, and also they reduce the airway symptom if the patient has got asthma and allergic rhinitis together. The important point is that proper application of nasal spray is important, and it should be used before exposure to a particular allergen for getting the best result. The peak effect of intranasal corticosteroid may take several days, so important thing is that they should be used regularly. And two most commonly used drugs, beclomethasone and triamcinolone, they can be used intranasally, but probably a long-term use of these drugs may affect growth of the children. So they are not advisable to use for a very long time. The common side effect of intranasal corticosteroid could be nasal irritation and nasal stinging. Another class of drug which is recommended for allergic rhinitis is leukotriene receptor antagonist. The montelukast is among so many drugs which are available among this category. The montelukast is the most commonly used drug, and this is the only drug which is of this class which is approved for the treatment of allergic rhinitis. So there is no other drug in this class. The study have found that the combination of leukotriene receptor antagonist and antihistamines could be as effective as intranasal corticosteroids. So they can be used again if the patient do not respond to a single anti-allergic drug. The combination of leukotriene antagonist and antihistaminic can also be considered if the patient fails to oral antihistamines, if he fails to intranasal corticosteroid or the combinations, or if the patient is not able to tolerate them for various reasons. And finally, if all these therapies like oral antihistamines, the intranasal therapies and leukotriene receptor antagonist, if all these therapy fails in allergic rhinitis, the final call is taken by giving allergen immunotherapy to the patient. Now, allergen immunotherapy involves the administration of a specific allergen to induce the immunological tolerance in the individual. So these allergens are administered either subcutaneously or given in form of sublingual preparations. They are kept below the tongue. And these type of therapy is particularly useful for patients with intermittent allergic rhinitis, which is caused by pollen, like tree, grass, or ragweed pollens. So for the pollen allergy, this type of therapy is highly effective. Also, it should not be given as a first-line therapy. It should be reserved for those patients who have failed other measures of treatment. The treatment for allergen with allergen immunotherapy should be done at least 3 years and to get the sustained benefit. Should not be stopped in between. And immunotherapy also reduces the risk of development of asthma in children with allergic rhinitis. One important thing to note about allergen immunotherapy is that this therapy is to be given under the supervision of a physician because the patient can develop severe anaphylactic reaction. So whenever such therapies are given, it should be under close supervision of a physician. The allergen immunotherapy, it is given weekly, where the dose of allergen is gradually increased over the course of 6 to 8 months, followed by maintenance injection of maximum dose every 3 to 4 weeks for 3 to 5 years. So it's a treatment with a lot of patience required in this case, a lot of supervision is required in this case. This is for injection. Slightly better form is sublingual immunotherapy, which is known as SLIT. It is preferred over subcutaneous immunotherapy due to convenience. Patient can take at home and relatively safe. Sublingual immunotherapy has lesser risk of developing serious allergic reaction as compared to injection. Now, as per the Indian guideline of allergy and asthma, some of these allergens are shown to have a high efficacy in allergen immunotherapy, like house dust mite and pollen. They have significant data, level 1 evidence of its efficacy as allergen immunotherapy, followed by mold and animal epithelia. The data is not as extensive, but yes, probably there is a significant level of evidence. Regarding other two options of immunotherapy, one Hymenoptera, which is a kind of an insect, and cockroaches, etc. The data is still not too much there, but the level of evidence is there. So what we can say that probably for the first three, we have the highest level of the first two or other, we have the highest level of evidence if you go for allergen immunotherapy. Now, there are a lot of decongestants which are used in the treatment of allergic rhinitis. It can be oral decongestant, it can be intranasal decongestant, and mostly these oral and intranasal, they are used without prescription. They are available in form of OTC. You can go to a pharmacy shop, you can ask for Otrivin, you can ask for Nezivion drops. A lot of nasal drops are available in form of for allergic rhinitis, and similarly a lot of anti-cold preparation, anti-decongestants, the decongestants are available. The problem with decongestants are the long-term use is restricted due to the side effects. Both oral as well as intranasal decongestants, they have side effect on the long-term use. The oral decongestant can cause agitation, insomnia, palpitation, and headache, whereas intranasal decongestant can cause rebound nasal congestion. They can also cause atrophic rhinitis and even rhinitis medicamentosa on very long-term use. So important point to note is that any of these two decongestants should not be used for a very long time without doctor's advice. The other therapies which can be used in very severe case which are refractory to other treatment could be oral corticosteroid, where there's limitation. There can be used of intranasal sodium chromoglycate. Intranasal sodium chromoglycate is effective in few patients, but definitely if the patient has pregnancy and suffering from allergic rhinitis, this is one of the safest drugs. So you can say that allergic rhinitis during pregnancy, the choice of intranasal preparation is intranasal sodium chromoglycate. The anti-IgE antibody, that is omalizumab, is the first monoclonal antibody to be approved for the treatment of asthma and also for asthma. Still, it is not approved for the treatment of allergic rhinitis. There are a lot many complementary alternative medicines which are used, like acupressure, acupuncture, etc. And if the allergic rhinitis is associated with certain conditions like nasal polyp and chronic sinusitis, then patients may go, or he may require to go for a surgery. So to summarize, we can say that allergic rhinitis is strongly linked with asthma and conjunctivitis. It is just not a disease of the nasal cavity. It may involve the respiratory tract completely. The allergen skin test is the best diagnostic method to confirm the disease. The second generation oral antihistamines are the mainstay of treatment. The intranasal corticosteroid with or without antihistamines are recommended in allergic rhinitis which are not responding to anti-allergics. And finally, allergen immunotherapy is recommended if the patient failed to respond to the drug treatment. Thank you.